Benefits regarding associated diseases. Randomized trials showed that the addition of a therapy designed to eradicate Helicobacter pylori in patients who tested positive for this infection led to a lower incidence of duodenal ulceration or gastric ulceration than no treatment. In another meta-analysis of clinical trials, the number of patients with Helicobacter pylori infection who would need to be treated for dyspepsia was greater than that for peptic ulcer disease. Studies have compared the prevalence of infection and deaths from gastric cancer before and after the Japanese government began a program to test for and treat Helicobacter pylori infection in 2013. After the initiation of the program, the number of treated patients in Japan more than doubled to approximately 1.5 million per year. While the number of deaths from gastric cancer steadily declined from 50,000 to 45,000 per year. An observational study in Hong Kong showed a significantly lower incidence of gastric cancer among patients older than 60 years of age who had received treatment to eradicate Helicobacter pylori infection than the expected number of cases in the general population. In a randomized, double-blind, placebo-controlled trial in South Korea, patients with early gastric cancer who received treatment for Helicobacter pylori infection had lower rates of metachronous gastric cancer after a median of 5.9 years than those who received placebo. Early-stage melanoma, type 1 or 2, is effectively treated with antibiotics to eradicate Helicobacter pylori infection. However, the treatment of more advanced stages of melanoma also involves surgery, radiation, chemotherapy, or a combination of these interventions. Randomized trials have shown that screening and treatment for Helicobacter pylori infection in persons who are starting or taking long-term non-steroidal anti-inflammatory drugs therapy, abbreviated NSAID therapy, reduces the risk of peptic ulcer disease. Data from randomized trials have shown increases in the hemoglobin level after eradication of Helicobacter pylori infection. Treatment regimens. Guidelines recommend that decisions regarding therapy routinely take into account whether the patient has had any previous exposure to macrolide antibiotics, e.g., clarithromycin, azithromycin, and erythromycin, and whether the patient has an allergy to penicillin. Because most patients with self-described beta-lactam allergy do not have a true allergy, skin testing should be performed so that amoxicillin-containing regimens can be a treatment option if testing is negative. Other factors in making decision include other allergies, potential adverse reactions, e.g., gut symptoms, and also tendinitis with fluoroquinolones, which is a particular concern in older men, costs, insurance coverage, and availability. Treatment with clarithromycin combined with amoxicillin and a proton pump inhibitors, abbreviated PPI, is listed first among the recommendations for patients with no history of antibiotic treatment for the infection. Another commonly used regimen includes bismuth, tetracycline, metronidazole, and a proton pump inhibitors, i.e., bismuth-based quadruple therapy. This regimen was the standard treatment in the early 1980s but was then largely replaced by the simplified clarithromycin-based triple therapy regimen. Guidelines recommend the use of bismuth-based quadruple therapy for 10 to 14 days. A randomized trial comparing bismuth-based quadruple therapy with clarithromycin-based triple therapy showed no significant difference in the percentages of patients in whom Helicobacter pylori was eradicated. The percentages of patients who adhered to treatment and who had adverse events also appear to be similar in the two groups. Doxycycline is not considered to be as effective as tetracycline in the treatment of Helicobacter pylori infection, as resistance to clarithromycin has increased in many parts of the world. The bismuth-based regimen is commonly used. Appropriate candidates for this regimen include persons who have been exposed to a macrolide, have allergy to penicillin, or both. Clarithromycin-based triple therapy can also be used in such patients if amoxicillin is replaced with metronidazole. In patients with macrolide exposure and penicillin allergy, the bismuth-based regimen is essentially the only option. If the first two regimens fail, testing for antimicrobial resistance could be considered, or one of the other 5 recommended treatment regimens could be used. Strategies to address antimicrobial resistance. Guidelines in the United States have suggested that clarithromycin-containing regimens not be used when the level of clarithromycin resistance is more than 25%. A recent meta-analysis of 178 studies, which involved more than 66,000 isolates from all World Health Organization regions, abbreviated WHO regions, assessed the prevalence and trends in Helicobacter pylori resistance to commonly prescribed antibiotics. Rates of primary and secondary resistance to clarithromycin, metronidazole, and levofloxacin were 15% or more in all regions, except for primary clarithromycin resistance in the Americas, 10%, and Southeast Asia, 10%, and primary levofloxacin resistance in Europe, 11%. The prevalence of primary combined resistance to both clarithromycin and metronidazole was 19% in the Eastern Mediterranean region but less than 10% in other regions. Primary resistance to amoxicillin and tetracycline was below 15% in all regions. Antibiotic resistance rates were heterogeneous across countries within the various regions and were generally lower among children and higher among adults. For all the antibiotics, there were significant associations between eradication treatment failure and resistance detected before treatment. A recent observational study showed that only 35% of patients who had been treated for Helicobacter pylori infection underwent follow-up testing to confirm eradication, and that many patients who had treatment failure were retreated with the same regimen. It is critical to test for eradication after treatment is completed and to use a different regimen when eradication failure is documented. One randomized trial showed that regimens with rifabutin were effective rescue therapies in patients with treatment failure who had Helicobacter pylori infection that was resistant to both metronidazole and clarithromycin. Guidelines. All the recommendations discussed above are consistent with the guidelines for the evaluation and treatment of Helicobacter pylori infection. An important recommendation in the 2017 guidelines was that all infected persons should be treated and then retested to assess for successful eradication. Although the recommendations of other guidelines are generally similar, they vary somewhat in view of regional differences in drug availability, antimicrobial resistance, and rates of gastric cancer. It is recommended that all treatment regimens be administered for 10 to 14 days.